MidCon 2026 for giving me the opportunity and giving our institute for this presentation. So we'll go on to the case presentation. Dr. Heblin and Dr. Deepika will be presenting the case. So you can start the case presenting.
This is a case summary of 2-month-old male baby with a weight of 5.4 kilogram. Informant is mother and reliable. Presented with complaints of gradual increase in head size over the past 1 month, which is not associated with irritability, feeding difficulty, vomiting, seizure, breathing difficulty, jerky eye movements or fever. Normal activity was noted by the mother. In the antenatal history, mother gives history of gestational diabetes mellitus and she was on OHA. Antenatal ultrasound showed some neurological abnormality and no history of any fever with rash, drug intake during pregnancy. This is a second child of non-consanguineous marriage, delivered at time via cesarean section in view of previous cesarean section. Birth weight was 2.5 kg. And the child cried soon after birth with normal color and activity. Apgar score was not available. No history of any resuscitation. History of NICU admission for 3 days in view of neurological abnormality. And there is no history of jaundice. The social smile and head control not attained but alert to sound. Child is fully immunized for age. In family history, elder sibling is normal and no similar history in the family. There is no history of any congenital anomalies in the family members. On general examination, the child is active. Macrocephaly is present with AF bulging, which is 5 into 5 centimeter wide. The posterior fontanelle is open. No dilated scalp veins were present. Sunset sign present. Bilateral pupil equal and reacting to life. No obvious facial and other congenital malformations like myelomengosal or spina bifida noted. On vital signs were heart rate with 140 per minute, which is regular. Blood pressure of 98 by 54 millimeters of mercury. Respiratory rate of 28 per minute and temperature of 98.5 degree Fahrenheit. Weight was 5.4 kg, length of 58 centimeter and head circumference was 47 centimeter. On systemic examination, the CNS examination showed a power of 4 by 5 in bilateral upper limb and lower limb. Bulk was normal. There was lower limb hypertonia, which was more on the left side. Bilateral extensor plantar reflex were noted. On cranial nerve examination, there were no nystagmus, no ptosis, sunset sign present, follows objects, alert to sounds, no regurgitation of feeds. Back and spine were normal. CVS and respiratory system are within normal limit. To summarize, this is a 2-month-old male baby with 5.4 kilogram body weight whose antenatal ultrasound scan revealed some neurological abnormality, delivered via cesarean section with no history of resuscitation, presented with significant increase in head size for the past 1 month, with bulging AF and sunset sign. My likely diagnosis is congenital hydrocephalus waiting for shunt procedure.
Okay, then what are the findings which suggest that it's a hydrocephalus?
There is macrocephaly is present and head circumference is around 47 centimeter.
What should have been the ideal for this 2-month-old baby for head circumference
at birth, normal value is 33 to 35. This baby had 35.5 centimeter.
At birth.
2 months, it should be around 39 centimeters.
Okay. So this is 47 centimeters.
47 centimeters.
Okay, so that's the only finding you have to diagnose hydrocephalus in this case, or any other finding you have?
Sunset sign is present, sir.
Positive, okay.
Anterior fontanelle is also bulging.
Tense and looking bulging. So not fused. It's only 2 months old baby. So these are the 3 important findings you had: head circumference, AF bulging, and then sunset sign positive. Okay.
What is hydrocephalus? And what's the incidence of congenital hydrocephalus?
The word hydrocephalus is derived from the Greek word, which means hydro means water and cephalus means brain. This means abnormal accumulation of CSF in the ventricles of the brain due to mismatch between CSF production and absorption. Estimated prevalence is 1 to 1.5% and incidence of congenital hydrocephalus is about 0.9 to 1.8 per 1,000 live births.
Okay, so can you classify the type of hydrocephalus with some examples for each type?
Hydrocephalus can be classified depending upon the mechanism, like excessive production and defective absorption. Excessive production examples will be choroid plexus papilloma or carcinoma. In defective absorption, we can classify it again into communicating and non-communicating. In communicating, there will be no obstruction to the CSF flow. It can be congenital or acquired. Congenital will be achondroplasia or craniofacial syndrome. Acquired can be due to post-hemorrhagic like subarachnoid hemorrhage or intraventricular hemorrhage, post-infectious like TB or bacterial meningitis. Non-communicating hydrocephalus means there is an obstruction in the CSF flow. It can be congenital or acquired. Congenital include aqueductal stenosis, vein of Galen malformations, Kyrie malformations, Dandy-Walker malformations, and X-linked hydrocephalus. Acquired non-communicating hydrocephalus include suprasellar and posterior fossa tumors and posterior fossa hematomas.
Could you describe about the CSF formation, circulation, and absorption?
CSF is formed in the lateral ventricles by the choroid plexus. From the lateral ventricles, it enters the third ventricles via the foramen of Monro, and from the third ventricle, it enters the fourth ventricle via the foramen of cerebral aqueduct of Sylvius. From the fourth ventricle, it enters the subarachnoid space via three foramens. On midline, there is foramen of Magendie, and on lateral side, there are two foramens. Foramen of Lashka is there. In the subarachnoid space, it circulates there, and then it is absorbed by the arachnoid villi into the superior sagittal sinus, and the rate of formation is 0.3 to 0.5 ml per minute, which accounts for 20 ml per minute. So the CSF is cycled
20 ml per hour. 20 ml per hour.
20 ml per hour, and the CSF is cycled 4 to 5 times per day, and total volume of CSF will be around 200 ml, of which 30 ml will be in the ventricles and rest 170 ml will be in the subarachnoid space. Normal ICP values in neonatate 1.5 millimeters of mercury, 1 to 5 millimeters of mercury. In infants, it is 3 to 7 millimeters of mercury. In older children, it is 5 to 10 millimeters of mercury, and in adult, it's 7 to 15 millimeters of mercury.
Okay, how is the head circumference measured, and what is the normal value in a normal at birth, and how it increases with age?
Head circumference is measured by the occipital frontal circumference, and it is about 33 to 35 centimeters at the birth. At the age advances, there will be increase in the head circumference. At the age of 1 year, the infant attains 90% of the adult head circumference, and it reaches adult size by around 6 years of age. There will be 2 centimeter per month increase in the first 3 months, and from 3 months to 6 months there will be increase at a rate of 1 centimeter per month. 6 to 12 months it will be 0.5 centimeter per month. 1 to 3 years 0.25 centimeter per month, and 4 to 6 years there will be increase of 1 centimeter per year.
What are the signs and symptoms of hydrocephalus in neonates, infants?
Signs and symptoms mostly depend on whether sutures are open or closed. In infant, sutures will be open, so skull will expand, and the symptoms will be progressive increase in the head circumference, bulging tens anterior fontanelle, widely separated sutures, dilated scalp veins, sunset sign, frontal bossing, and there can be irritability or high-pitched cry, poor feeding and vomiting, dehydration, failure to thrive, and developmental delay. In older child, as the sutures are closed, skull cannot expand, so there will be rapid rise in ICB and symptoms will be severe. It include headache, projectile vomitings, papilledema, diplopia, lethargy or altered sensorium, Cushing's triad, seizures, neurological manifestations, developmental delay and failure to thrive, and dehydration.
In our case, the child, the 2-month-old baby didn't have much symptoms. Only there was enlarging the size of the head. What specific elements should be emphasized during the preoperative evaluation of this child coming for a VP shunt? Can you enumerate that?
It mostly emphasizes on assessing the GCS of the child. If it is poor, there will be risk of aspiration, and child may need post-op ventilation, and we need to assess whether child is able to protect the airway, and we need to check for raised ICP and measures to reduce it, and associated symptoms and coexisting syndromes and organ dysfunctions and electrolyte imbalances, medication details, and there can be airway challenges, fasting status and hydration status should be taken into consideration. Pre-op investigations include CBC to rule out anemia and infection, serum electrolytes in which hyponatremia is more common in these patients, renal functions and blood glucose, ultrasound skull in case of infants, CT or MRI brain for older children. We can also look for fundoscopy and transcranial Doppler. Next.
Okay, you said the anterior frontal area is bulging, isn't it? What does it mean? And how does it influence your anesthetic management?
It indicates there is a raised ICP and exceeded compliance. It is usually seen in infants because sutures are open. Increased CSF volume, that pressure will be transmitted, so fontanelle will be tense and bulging, leading to vein matter. If not treated, it leads to vein matter compression and impending coning. Anesthetic relevance include we should avoid further rise in ICP, avoid hypoxia and hypercarbia, and maintain cerebral perfusion pressure.
That means in a child where our infant, where the AF4 is not closed or sutures are not closed, there is a gradual increase in the ICP happens, and which doesn't produce much symptoms because the compliance is there. So, as the Mendrockelli doctrine says that there is when the fluid increases, the compensation occurs with the brain matter because brain matter is compressed. So, to a certain extent, it happens like that, and later on, there will be development of symptoms. Whereas in the older children, where AF is closed or sutures are closed, the child can have manifestations or symptoms and signs early itself, early in the phase of illness. Okay. So why is a thorough airway assessment crucial in a child with hydrocephalus, especially in the context of associated syndromes?
In hydrocephalus, macrocephaly will be there, which will cause neck flexion in supine position. So there will be difficulty in aligning the oral, pharyngeal and the laryngeal axis. And there will be also difficulty in mask ventilation, difficulty in laryngoscopy also. The associated syndromes are with increased airway difficulty are the Arnold-Chiari malformation, Dandy-Walker malformation, Cruzen syndrome, Apert syndrome.
Why is atropine or glycopyrrolate often administered as a pre-medicament or during induction in these cases? What is the importance of that, arranging this or keeping ready?
It is to prevent vagal bradycardia during laryngoscopy and ventricular manipulation. We are anticipating a difficult airway, so there will be repeated attempts. These can lead to bradycardia. And to reduce secretions and to counteract opioid-induced bradycardia, glycopyrrolate is often preferred due to minimal CNS effect.
So dose of atropine, okay.
Okay, as you said, the ICP is raised, isn't it? The anterior frontal area is bulging. Okay, and you said you want to prevent further increase in ICP. Could you mention about what is CPP and what are your CPP target and how do you manage CPP within the normal range?
CPP is the pressure gradient driving the cerebral blood flow. It can be, CPP is equal to mean arterial pressure minus intracranial pressure. Why is it important in hydrocephalus? Means in hydrocephalus there will be ventricular enlargement which leads to increased ICP. As ICP rises, CPP will fall. If fall is below the critical level, there it can lead to cerebral ischemia, brain injury and risk of herniation. So we should avoid hypotension, hypoxia and hypercarbia. Our target cerebral perfusion pressure should be, in infants it should be greater than or equal to 40 millimeter of mercury. In older children 40 to 50 millimeter of mercury, and in adolescents greater than or equal to 50 to 60 millimeter of mercury.
So as a rule, avoid 3H, hypoxia, hypercarbia, then hypotension. Yeah, okay. What is the anesthetic plan for this patient coming for BP patient surgery, and compare the risk and benefits of intravenous versus inhalational induction?
Our anesthetic plan will be general anesthesia. We prefer IV induction whenever when IV access is secured because it provides the rapid airway control and better ICP stability. Inhalational induction is only acceptable when IV access is not available, but care should be taken to avoid hypercarbia and sympathetic stimulation.
Okay, would you prefer a opioid as an analgesic? If so, which opioid will you prefer and why?
Opioids are preferred. because it will blunt the sympathetic response to laryngoscopy, and reduction in cerebral metabolic rate will be there, and hemodynamic stability is attained, and provide intraoperative analgesia also, which will also lower the concentrations of volatile agents. The short-acting opioids like fentanyl and remifentanil is usually advised. Morphine is avoided because its long duration of action and which may delay neurological assessment, and its respiratory depressant effects can cause hypercarbia and further increase in intracranial pressure.
So when you use opioids, we usually try to use fentanyl or remifentanil if it's available, and avoid as far as possible avoid morphine. Okay, how do you manage the airway of a child with large hydrocephalus? Because that is the most important. Whenever you see a baby with huge head, this child doesn't have a huge head, but it can be so huge that very difficult to even the baby to lie on bed and to take into the OT to keep the baby on bed. So what are the factors which can affect that positioning and intubation?
It's an anticipated difficult airway, so positioning is very important. As the head is large, in supine position there will be neck flexion. So our goal is to align oral, pharyngeal and laryngeal axis. So we should place a shoulder roll or pillow and allow the head to rest in the neutral position, and assistant should support the head, and avoid excessive neck flexion as it causes impairment in the venous drainage, which can further increase in ICP. Intubation, we should ensure the adequate depth before laryngoscopy, and use VLS whenever it is available, and gentle technique, and avoid multiple attempts, and avoid coughing or bucking.
So you should have to take special precautions and preparations in intubation or managing the difficult airway, anticipated difficult airway in this patient.
Even after inducing anesthesia, and your goal is to still avoid further increase in ICP, isn't it? So what are the position you opt for? You are planning for a ventriculoperitoneal shunt, isn't it? So what is the ideal position, and what are your concerns regarding that position?
Ideal position for the surgery will be supine with head turned to opposite side. So there should be head elevation 15 to 30 degrees to promote this venous drainage, and avoid excessive neck rotation to the opposite side, because it can cause jugular compression in the opposite side, and it will further increase the cerebral congestion. And we should secure the ET tube well, because the surgical field is near to the head, near to our tube, and there will be risk of hypothermia because of the large exposed area. So we should use warming blankets.
Okay, what are the goals for ventilation in a child with hydrocephalus, and why?
We should maintain a normocapnia with a PaCO2 of 35 to 40 millimeters of mercury, and avoid hypercapnia, which will increase the intracranial pressure. If there is acute increase in ICP, we should mildly hyperventilate the patient, but avoid prolonged hypocapnia also, and also ensure adequate oxygenation with a SpO2 of more than 95%.
During neurosurgical procedures, you might be quite commonly hearing the term that tight brain. Surgeon used to say the brain looks tight, isn't it? Heard about that?
Yes.
Okay. What all things you can do to improve the situation?
Tight brain is whenever we tell that brain bulges after dural opening, it may be due to raised ICP, hypercapnia, inadequate depth. So we can manage with mild hyperventilation. We can give mannitol, hypertonic saline, and deepen anesthesia with propofol, and ensure head elevation and neutral alignment. And surgical CSF drainage is one option.
If you are using volatile agents to deepen the plane of anesthesia, make sure you are not going above 1 Mach. Above 1 Mach, it will further increase the cerebral blood flow.
The surgeon opens the ventricle and there is a sudden severe bradycardia and hypotension happening. What is the most likely diagnosis, and how will you manage that?
Most likely cause will be because of sudden drop in ICP, there will be brainstem stimulation, which in turn trigger the trigeminocardiac reflex. So immediate management will be inform the surgeon, stop the surgical stimulus, and administer atropine, support the BP with fluids or vasopressors, and ensure adequate oxygenation.
Okay. You said if the surgeon is complaining about tight brain, you'll do so many maneuvers. One of the maneuver you said you'll use pharmacological measures. So what about mannitol? What's the mechanism of action, and what's the dose of mannitol?
Mannitol is an osmotic diuretic. Dose is 0.25 to 1 gram per kg IV over 15 to 20 minutes. It reduces the ICP within 15 to 30 minutes. The side effects include hypotension, electrolyte imbalance, and there will be a risk of rebound increase in ICP and renal stress.
What is your fluid of choice for this selective shunt surgery, and justify that? And what are your considerations for intraoperative glucose management in this case?
We usually avoid hypotonic and glucose-containing fluids like 5% dextrose and DNS. A preferred IV fluid in an infant and toddler is isotonic balanced crystalloids containing low concentration of dextrose, that is 1% DRL is advised. If older children, we can use ringer lactate. Our goal is to maintain euvolemia, avoid hyperglycemia and hypoglycemia.
You said about 1% DRL. Can you just explain how do you prepare that 1% DRL?
1% is DRL is prepared with 2 ml of 25% dextrose added to 48 ml of ringer lactate.
Okay, so that will provide some glucose and the child would be hypoglycemic. At the same time, there would be hyperglycemia as well. So that is the ideal solution for an infant coming for any surgery. Okay, that doesn't be the hydrocephalus surgery alone. Any surgery coming for, any infant coming for surgery, this is ideal fluid. Okay.
What are the different types of shunts? I mean, the shunt procedures done for hydrocephalus surgery.
The most commonly performed one is the ventriculoperitoneal shunt. It has large absorptive surface and it technically easier and handles a large CSF volume. But it has disadvantages also. It can cause peritonitis, abdominal pseudocyst, bowel perforation, hernia, failure with abdominal adhesions. Other less commonly used shunt procedures are ventriculoatrial, ventriculopleural, lumboperitoneal, ventriculosubgaleal shunts.
Okay. So what are the common intraoperative complications that you have seen or that can happen during VP shunt surgery?
Most common complications include bradycardia because of triseminocardiac reflex, hypotension, air embolism, blood loss, hypothermia, shunt malfunction or misplacement, and electrolyte disturbances.
What are the different types of shunt valves? Not shunt procedures, different types of shunt valves used for these hydrocephalus surgeries.
Different types include fixed differential pressure valves, hydrostatic valves, which include suction control device, flow reducing device, and gravitational valves. There will be programmable valves and hybrid valves, third and fourth generation.
And can you show the different types of valves here?
This
Okay.
picture summarizes the various types of valves.
Okay. So a child with a programmable VP shunt needs an urgent MRI for any other issue. So what specific steps must be taken to undergo the MRI?
The most commonly used programmable VP shunt valves are MRI compatible. But before procedure, we should identify the valve type and ensure the MRI compatibility. Also, we should inform the neurosurgery team and document valve settings pre-MRI and perform MRI only if device is MRI safe. And recheck valve settings immediately after MRI also and reprogram valve if settings are changed. The child should be monitored for any signs of shunt malfunction.
Now the valves are MRI compatible because the child needs frequent MRI, may need, because as the child grows, we have to do the shunt revision. So now the valves come with a programmable valves and MRI compatible compared to earlier which was not like that.
What are the causes of delayed recovery after hydrocephalus surgery?
It may be due to residual anesthetic drugs, opioid or sedative overdose, and electrolyte imbalance like hyponatremia can cause delayed emergence, hypothermia, hypoglycemia, and there may be it may be due to intracranial complications like hemorrhage, any acute increase in ICP, acute hydrocephalus, pneumocephalus.
What is PONV? Why is PONV aggressively prevented and treated? What is the problem of PONV in this child?
Postoperative nausea and vomiting will increase the intracranial pressure and there will be risk of shunt displacement and it can cause CSF pressure fluctuations and there will be risk of wound or shunt complications and might lead to dehydration and electrolyte imbalance. So it should be treated aggressively to avoid all these complications.
So prevention as well as treatment is important.
Are you worried about postoperative pain in this case?
Yes, sir.
Yes. Why?
because post-op it will increase the
Yeah,
further increase the ICP.
Further increase the ICP. Okay. So what are your options? for
Multimodal
post-operative
analgesia is preferred. Baseline analgesia with paracetamol 15 milligram per kg IV or 20 to 30 milligram per kg rectal suppository. Opioids can be given, but those should be titrated carefully, and we can give scalp block or local infiltration.
Okay. What are the signs of shunt malfunction in the immediate postoperative period?
The child can present with the altered consciousness, persistent vomiting, bulging fontanellae, headache, bradycardia or hypertension, seizures, failure to improve neurologically, and local swellings along the shunt tract may be there.
Okay. So close monitoring of the child in the immediate postoperative period is very essential to rule out all this shunt malfunction. A child with BP shunt is supposed for lap appendicectomy. What are your concerns and goals?
Since it is a laparoscopic surgery, the pneumoperitoneum can further increase the intracranial pressure. It can lead to VP shunt malfunctions. There is increased risk of infections and positioning related issues will be there. Our goal is to avoid hypercarbia, avoid hypoxia and avoid excessive pneumoperitoneum pressures, and to maintain smooth induction and emergence, and to avoid excess Trendelenburg position, and ensure adequate depth of anesthesia and maintain adequate cerebral perfusion.
Okay, during a revision surgery, a surgeon is finding very difficult to attain hemostasis. And suddenly you notice that your ETCO2 starts dropping. It comes down to 20 millimeters of mercury, and the saturation also started falling. What will you do? What is your differential diagnosis?
Here the most probable cause might be venous air embolism. So our next step will be advise the neurosurgeon.
Why they are prone for venous air embolism?
Because
It's a neurological surgery. There will be veins will be open and air can be
Yes,
entered.
those are non-collapsible veins.
Veins.
so we'll ask the surgeon to discontinue and flood the surgical field with the fluid, and we'll compress the jugular veins and position the operating field lower than the heart to prevent the further ingestion of air, and ventilate the lungs with 100% oxygen. Nitrous oxide, if we are using, it should be discontinued, and attempt to withdraw the air through central venous catheter if it is in situ, and treat any hemodynamic consequences, and if there is hemodynamic instability persisting, then turn the patient to left side down position.
What's that position called as? Any idea?
Durance.
Durance.
Yeah. Okay.
Yeah. I mean, this is a newer procedure which has been done for shunt surgeries. It's not done in many institutions, but neurosurgical specialized institutions, they used to do this endoscopic third ventriculostomy. What are your anesthetic concerns when a child is supposed to undergo ETV?
ETV is a minimal invasive procedure creating an opening in the floor of third ventricle. There will be high risk of bradycardia during floor perforation. We should keep atropine ready, and there will be risk of venous bleeding into the ventricles, which can be catastrophic, and there will be potential for venous air embolism due to irrigation and head elevation. And irrigation with warm saline can cause hyperthermia, and we also need a rapid emergence to assess the neurological status post-operatively.
Suppose you have an infant posted for hydrocephalus. On examination, you are finding out there is a murmur, and you send the patient to the cardiology department for further evaluation, and they find out there is a left to right shunt. What are your concerns?
This is a challenging situation. Here, our neurological goal is to keep a mild hypocapnia and normotension or hypertension for cerebral perfusion. But our cardiologic goal is to avoid decrease in the pulmonary vascular resistance, making hyperventilation undesirable. So, the anesthetic plan requires a delicate balance. We should maintain adequate oxygenation and avoid hypercapnia, which will increase the pulmonary vascular resistance. But at the same time, we should avoid extreme hypocapnia also.
Okay, well done. You have quite well prepared with all the possible questions which can be asked in hydrocephalus case. Thank you very much, both Evelyn and
Thank you, both of you. You people have done a wonderful job. I know, Sir could have put so much of effort behind that. And I congratulate Venugopal sir and you both of you for performing very well. And I take this opportunity to thank ISA Kerala State Chapter and also Dr. Sam, whom I personally know very well, for having me for this event. Thank you.
Thank you, Dr. Biju, for being with us in this case presentation. Thank you.